Welcome back, everybody. Another episode, Psychiatry Podcast. We got a special one for you guys today because we have a guest. Logan, I'm going to let you introduce our guest. Take it away, Dr. Noone.
Yeah, let's go. Yeah, so I've known Will Summers here. I mean, we were trying to exactly calculate when we met, but it was way back in 2019. What time of year? I don't know. Who knows? But we were living in Yakima, Washington at that time. Very rural area of Washington. Beautiful part of the country if you've never been there. Maybe 2-3 hours inland from Seattle, like high desert mountain range, land of hops is how I kind of remember it. We probably met at a brewery or something. You started dating and falling in love and asking that woman to marry you, one of my classmates, who she's now a surgeon in her residency, just like us. And she's got a crazy story too. So for you listeners, we'll get her to eventually come on and tell her wild story to becoming a surgeon. But we're interviewing Will today. Will, I don't understand your exact work all the time, but I'm excited to get into the details of it tonight. I know you're a therapist. You told us you specialized in ACT therapy, and like you want to get into moral foundation theory. I'm just really excited to interview you and see what it's like for you, because we both work in such a similar industry. So thank you so much for being here.
Yeah, certainly. And thanks for having me, both of you. And Logan, so Kelsey and I started dating around August of that year. So we probably met around September, October when it was nice and cold in the high desert of Yakima.
Right.
So off of what Logan was saying, I'm a psychologist. I've been in practice for a couple of years now. And last October is when I took our big bad final board exam, passed it, thankfully. So it'll happen one day, guys. You'll get there. At least that's what they kept telling me. And so currently I'm in a private practice setting. So I do therapy for about 40 to 50 minutes, typically once a week with people. I personally am happy to be more flexible if people want to go twice a week or if people want to go once every couple of weeks or once a month. I just kind of let it be up to the client and make sure we collaborate on that. And yes, I practice ACT, which stands for Acceptance and Commitment Therapy. And I'm sure y'all will have some questions and thoughts on that as we go.
Will, before I became aware of doing this episode, I honestly had never even heard of ACT therapy before. So ACT therapy, that stands for Acceptance and Commitment Therapy. And the definition that I was able to find for it is that it's a type of mindful psychotherapy that helps you to stay focused on the present moment and accept thoughts and feelings without judgment. So my first initial reaction was, oh, that kind of sounds like CBT. But upon further and deeper inspection, so CBT has that component where you're taking those negative thoughts and you're kind of reframing that, versus ACT is more of just learning to accept your feelings and recognizing that some of these negative emotions that we may deal with on a day-to-day basis is part of the human condition, that is an inseparative part of the human experience. Is that right? What more can you tell us about ACT and how it differs from the other popular therapy techniques that are out there?
Certainly. And I think that's a really good summary, first of all. And so CBT, cognitive behavioral therapy, to geek out for a quick sec, there's 3 waves, technically speaking. The first wave is looking at more of the behaviors. If you're sad, if you go exercise, you'll feel better. So first wave is very behavioral. Second wave was cognitive, where they added the cognitive piece, so the cognitive behavioral, and that's Aaron Beck in the 70s and 80s. And that was, you have thoughts, feelings, and behaviors. It's kind of a triangle that all influence one another. And if you can change one of those 3 points in the triangle, the other 2 will change as well. And then ACT is the third wave of CBT, if you will. So it's related, but it does differ from that second wave in that exactly what you were saying. How can we accept our thoughts and feelings in the service of our values? And I think probably the most important differentiation between it and CBT is CBT will say, like, recognize that your thoughts are dysfunctional, change your thoughts, try to change your feelings if you can. But ACT says, I don't think we can change our thoughts. I don't think we can change our feelings. What we can do is acknowledge them and recognize them, and then keep our eyes on what's most important to us and still move in that direction, even if our thoughts and feelings are difficult. Again, where CBT would say, can we make the thoughts and feelings less difficult and then do what matters? ACT says, let's do it the other way around. Do what matters, even if things are difficult. Does that make sense?
So it's more action-based versus CBT. Am I understanding that correctly?
Yeah. So what I would say is ACT, they named it that for a reason. So because it is very action-based. That's why they don't say ACT, they say ACT because they want it to be active. And there is, again, that mindfulness piece that you were saying. So there is kind of this internal, more geeky, mindy, cognitive piece that goes into play as well. But yeah, it does look different from CBT in that we're not trying to poof away bad thoughts and unwanted feelings, if you will.
So, Will, I can tell you're very passionate about ACT therapy. I'm wondering, in your clinical practice, what is the reason for that? Is ACT superior in terms of patient responses versus CBT or other therapy modalities?
Yeah, so I will 100% acknowledge some bias here that most of the research that I'm privy to is pretty supportive of ACT, but I will like zoom out first and say, when studying psychotherapy in general, the modalities don't make up a big difference between what therapy is or is not effective. What we found is the three common ingredients, and let me know if y'all have heard this. I don't want to rehash stuff that y'all have talked about before. The three common ingredients that make therapy work is one, the relationship between the clinician and the client. Two, that the clinician has a theory. It doesn't matter which one exactly, but has a theory. And three, that the client believes in that theory. So, all that to say, CBT or ACT, I do think there is some important advantages ACT has. Then I'll kind of go back to my original response was the research I have seen has pretty consistently talked about ACT being more effective in a broader base of populations. And one of the most telling or damning pieces of evidence that I've seen says positive self-talk, which is commonly attributed to CBT, of like, tell yourself like, oh, I am smart, I am good, I am nice, I am attractive. So like that positive self-talk is extremely, extremely effective until you actually need it. So if you're going to go ask out that hot chick on a date and you're like, man, I'm good looking, I'm a catch, you feel good about it until like you walk up to her and you're like, oh, damn.
Then you turn around.
Yeah. Suddenly I don't believe it. Yeah. So that is, again, where ACT would say, yeah, your brain's going to say, hey, Will, you're ugly. Hey, Will, you're awkward and you're stuttering. Hey, Will, you're silly. Hey, Will, she's out of your league. Notice those thoughts, accept those thoughts, and still do what it takes. We don't have to get rid of those thoughts first. So all that to say, the geeky research I've seen says ACT has some benefits over CBT at this point.
Interesting. I like it, June. I don't know what, so it's funny. It just has me thinking. So I'm on my addiction rotation right now in psychiatry with Dr. Paninti. He's like this old school CBT at our psychiatry program. I think very highly of him. I consider him a role model. He asked me what I wanted to really dive into and work on this month. And I told him, I was like, well, look, like I respect your practice so much. I think I want to focus on CBT. But perhaps maybe now, like you're saying, the third wave, the maybe new and improved CBT is this ACT therapy, So I'm excited to learn more, but I'm very curious about, do you know anything about the origins of ACT therapy? And why I ask is I was watching this YouTube video and kind of like what you were saying, like the three waves of therapy, like it was behavioral, then cognitive, and now you're saying ACT therapy. So I was watching this YouTube video about ACT therapy, trying to learn more. And this psychologist was talking about how ACT therapy came about from scientific conclusions. And she said previously, new theories in therapy were more like, okay, a therapist who was doing a really good job would then be like, okay, well, this is working really well for me. I'm going to try to study this and apply this to a greater population and maybe draw conclusions from that. But does that resonate at all with you, Will?
Yeah, so that is one thing I deeply value about ACT is it has a very rich history in science and being studied and researched.
Your dogs agree.
That's not
Sorry,
my dog
guys.
this time.
That's my dog.
Shoot.
He still agrees too.
He is good. He's good. Yeah, so Steve Hayes is one of the few co-founders of ACT, and Steve Hayes is very open about spending about the first 20 years of ACT's lifespan, if you will, researching it and making sure that it passed a bunch of very stringent standards before putting it out to the public. Because like you were saying, other clinicians would be like, hey, this is working well. Let me kind of going from theory to information instead of going from information to theory. And I forget if that's inductive or deductive. It's been a long time since I took the stats in basic research classes. But as a quick quick review of the history of ACT. So Steve Hayes, he himself suffered from panic attacks throughout his life, and one day just realized like kind of the CBT stuff wasn't working for him, and he said, what if I did, instead of trying to like fix the anxiety, leaned into it. So then he called on functional contextualism, which is an approach to science and philosophy that basically says whatever is true is what gets you towards your goals. And so if your goal is to never feel anxious, eventually you stop leaving your house because the world is scary. And so you say that behavior is true, but then you ask at what cost? So it's an approach to philosophy and approach to science. I think Karl Popper is the guy who I think writes a lot about philosophies of science, if you want to read more there. And then out of that philosophy of science, out of functional contextualism, he turned to relational frame theory, or RFT. And essentially it is like how we relate our inner experiences to thoughts and words. And then how if I hold this up, this is a ring for those who are not seeing. I hold this up, you see this, you know the word ring, the gerbil noise that comes out of my mouth means this thing. If I just told you like ring, you would automatically know. You basically make all the connections of like the noise, the thing you see, and the thing you think. So ACT says all these processes are happening so fast, and that's why we can connect any stimulus to any other thing. Like if I say, Logan, how does a pencil remind you of your wife? What answer could you come up with?
They're both useful and
Perfect.
skinny.
Useful and skinny. Good answer. Way to save that one. And that's it in theory. Is like our brain can take any stimulus and connect it to any other thing. Therefore, it's really, really hard to run from your brain, run from your thoughts. So Steve Hayes studied this for about 20 years, and in like the early to mid 90s, he put out a book, Get Out of Your Mind and Into Your Life, originally intended for people that were in the prison systems that felt pretty hopeless about life. It became such a big hit that he went mainstream with it.
That's amazing, Will. Thank you for that in-depth explanation. So I'm going to confess something. I am a moron. So I'm going to ask you, Will, to kind of dumb that down one notch for me. So say if I was a patient, and hopefully, the reason why I wanted you to do that is hopefully the listeners, we have a lot of people that are psychiatrists, other residents. Hopefully they can, listen to some of your techniques and utilize it in their practice as well. So say I'm your patient, I come to you and I say, Dr. Summers, I'm feeling super anxious. I'm worried that this podcast episode is not going to turn out incredible. What would you tell me? How would you apply ACT into that situation?
Certainly. First, I'll say that's a bunch of like geeky science jargon that I use that I would probably never talk to with a client unless they wanted to know or unless they asked specifically. And so, yeah, you were saying like if your brain is saying like, hey, Joon, this podcast episode is going to suck. And you're saying, hey, Will, what would you say back in like a therapy session? Is that right?
Yes, exactly.
Perfect. So, yeah, I would say first, I would say notice that thought. Even simply saying, I am noticing my brain is saying this podcast episode is going to suck, can get a little bit of distance from that thought. The idea is not to change that thought or get rid of it. Because if you sit here and try to tell yourself, this episode's going to be great, this episode's going to be great, your brain will instantly come behind that and say, no, it's not. This episode's going to suck. Like, we can't lie ourselves into feeling good when we don't feel good. And again, as a quick geeky side note, they did research where they hooked people up to... not an MRI, scan where the bunch of little leads are on the brain.
EEG, probably. Yeah, EEG. Electroencephalogram. Yeah, brainwaves.
Thank you. Yes, thank you. They hooked people up to an EEG, and they had them say, I am fat, and then say a different group say, I am noticing my brain is saying I am fat. They controlled for body size, and they controlled for how do you feel about your body, like before the study. People that said I am fat, they reported more stress, and I think it's right frontal lobe activity flared up where there's a little bit more like negativity or anxiety is kind of where that is processed in the brain. And then people that said I'm noticing my brain is saying I am fat, like their brain lit up a little bit more evenly, and they reported a lot less stress from saying it out loud. So there's some cool like geeky neuro studies that like simply just saying I'm noticing my brain is saying this podcast episode is going to suck, because that's a little bit of distance from that thought. That'd be my first thing. Second thing, I would say, like, look at the emotions. Like, man, you might feel anxious right now. You might feel angry. You might feel upset. There's a function and a purpose to that. Instead of trying to get rid of it, like, lean into it. Like, almost as if you're giving that emotion the microphone. Like, okay, anxiety, what do you actually need to say? When my guess would be your anxiety would be saying, I'm really invested in making sure this is a good episode. And that's not a bad thing. but it's like almost in this like really vicious gift wrap that makes it like unappealing to touch. But if we can get through that, like, oh, at the core of that is something really good, we can then focus on our values, which is, can you bring your best foot forward even when your brain is saying this episode is going to suck? Because making a good podcast is important to you. Does that kind of make sense as a semi-long-winded answer?
Absolutely. Yeah. Thanks so much for that, Will. That was amazing.
It almost sounds like ACT therapy is really leaning into kind of a concept I really like and I use a lot with my patients is like anxiety. I kind of feel is like an evolutionary trait. And me and June have talked about this. Maybe even like depression is an evolutionary trait. And like it does fuel you to perhaps do something about that. Like when that gazelle is being chased by that tiger or whatever, you know, the lion, and it feels anxiety, it's running away and it's working hard. Perhaps it's maybe the same about it. Some level of anxiety, some level of depression. And, you know, how we were describing that to June, like kind of leaning into those negative emotions, those distress, and using those to like act and do something about it. I dig it. I dig it. One thing I really wanted to kind of ask you about. So, you know, me and June and your fiance all went to osteopathic medical schools. We talked a lot about, of course, how like function and brain and muscles are all interrelated, right, to produce healthy outcomes. And, you know, I have a bad back, right, a bad lumbar spine, lower back from being overweight, maybe doing too heavy of, you know, squats and deadlifts when I was younger or something. It hurts. And I know that if I become more flexible, it doesn't hurt as bad. Like, so I need to use that motivation and that knowledge to, you know, do more yoga, engage in more of those kind of practices. So it seems like ACT, I want to get into the 6 core ACT processes or whatever they're called, but kind of more globally, the idea of psychological flexibility. I thought that was a really badass concept. Can you talk about that a little bit?
Yeah, certainly. And I think you explained it like you're kind of on the same side of the coin that I explain it to clients is like, why do we need flexibility in our body? Like if you had zero flexibility, why would that be a bad thing? And go ahead, one of y'all answer.
Well, you wouldn't be able to function as like a normal human being. You wouldn't be able to do the stuff that you want to do, and it would severely limit your lifestyle.
Yeah, muscles would atrophy, you know, the ligaments would get really tough and they literally couldn't move. So like June said, you couldn't even do all the things of daily life.
Perfect. Exactly. Things would hurt, and yeah, like your life would get narrower and narrower. If you had instantly zero flexibility, like maybe you could move for a little bit, but like again, eventually you'd only be able to like sit and do nothing, which would be a really hard existence. So psychological flexibility is kind of that same thing. If you have a phobia of dogs, and every time you see a dog, you run away, you avoid it, and you try to like fight that fear and fight that anxiety, your life gets narrower and narrower to the point where, man, if every time I see a dog, I run away from it, I go to the other side of the street, eventually seeing a dog on TV will start to trigger that same anxiety reaction. Reading about a dog in a book, and then eventually thinking about a dog will get that same anxiety reaction. And again, to kick back to what we said earlier, it's really hard to get away from your own thoughts. If a pencil can remind you of your wife, like a pencil sure as shit can remind me of a dog, you know? Mm-hmm. So we need flexibility. That way our brain will tell us dog, run, dog, fight, or whatever, you know, kind of an instant response to it. We needed to have a flexible repertoire of behaviors or a flexible options. Instead of I see a dog, I run, can I see a dog and be mindful of what's going on in my body? If my best friend has a dog and I haven't gone to his house in 5 years because I'm afraid of his dog, can I focus on my values and say, man, he has a dog, but my values lie in like seeing his dog. Can I see a dog and accept that I'm going to be a little bit nervous? And obviously building up to that. If you have an intense dog phobia, we know flooding, which is like, you know, dumping like a snake into your lap is like the quickest way to get over a phobia, but it's also extremely, extremely stressful. So I'm not saying if you have a phobia, go out and like touch a dog if you're afraid of dogs, just to clear that up.
Well, how difficult is it in real practice to help somebody break that cognitive rigidity? I mean, all this sounds great on paper. It sounds great for an academic discussion. But my experiences, at least as my role as a psychiatry resident, has been when somebody has that level of fear, that level of phobia, that they're here in the inpatient psychiatric hospital where I'm, conversing with them. Um, it's extremely difficult that I don't even know where to start that conversation. So how is it for you, like in working in the setting that you're working on, and how successful are you in helping people break these cognitive rigidities?
Right. So there's a specific part of ACT that it's not one of the six processes that Logan mentioned, and I'll make sure we go over those point by point at some point if you're open to that. But this specific thing you're talking about, June, is what's called creative hopelessness. So again, if y'all want to like Google that, like it'll kind of talk about this specifically. But yeah, that was one of my first questions was, why do I want to be mindful of the present moment if the present moment's extremely painful? So it's similar-ish, kind of what you're saying, June, is like, how do you get buy-in in another word? Um, so creative hopelessness essentially looks at if we have the agenda of control versus the agenda of values. So if your agenda is to control thoughts and feelings and emotions, again, like your life gets narrower and narrower. I never want to feel anxiety, therefore I stopped going to my friend's house who has a dog. I never want to feel heartbroken again, therefore I stopped dating. And again, if that's your primary goal, then man, you're living the good life according to yourself. But if the alternative is like an agenda of values or an agenda of flexibility, if I want to be married someday, I have to be willing to risk being hurt, because to love anything is to be vulnerable, per C.S. Lewis. So creative hopelessness kind of goes through a few questions that kind of help loosen our thoughts and feelings up about pain. It'd be like, what's difficult for you right now? Like, oh, it's anxiety. I'm afraid of dogs. What have you done? What have you tried? Oh, I've tried running away from them. I've tried fighting them. I've tried deep breathing, but like I'm still really afraid. And then what does it cost you? Like, what is it costing you to continually run away from dogs, to fight dogs? It's costing me hanging out with my best friend. It's costing me, I want a dog, but I'm too scared to get one. So what have you done? How has it worked for you? And what does it cost you? And typically you can get some buy-in when people recognize like, man, this agenda of controlling my emotions and controlling my feelings has cost me something I'm not willing to pay. Oftentimes then I'll follow up with, man, are you open to trying something different? Even something that your brain might say is crazy. And oftentimes people are, yeah, I'll try anything at this point. So hit rate is pretty successful. I would say like 80-90%. Some people say, nah, like it is never worth it to me to feel heartbroken again. And then that just changes the conversation.
And the first step to setting somebody on this ultimate pathway of achieving their final goal is to recognize that those negative emotions that they're feeling, whatever it may be, anxiety, depression, is part of the human condition, and that there's nothing wrong with experiencing it. That you have to just acknowledge it for what it is, as being an innate part of the human conscious experience. So, Will, my follow-up question to that is, how receptive are patients to hearing that sort of message? And the reason I ask that is because I think when we talk about the culture today, I feel like there's this belief that all negative emotions are due to something wrong with their external environment, right? You're feeling depressed, not because it's part of the innate human condition, but because there's something wrong with your family, or because your friends are assholes, or whatever it may be. But there's this overall culture, especially when I talk to in our pediatric populations, in our teenagers, right? I feel like they've been bombarded with this message that whenever you're feeling bad, it's not because of what it's a natural reaction that they might feel because they're human beings, but because there's something wrong on the outside, something externally that needs to be rectified. So, given that kind of culture, how, especially for your younger patients, like, is that a message that maybe they find relief in, or do they have like a negative reaction, like saying, no, I'm not supposed to feel this way? What's been your experience, Will?
That's a really good question. So right now I'm probably 60%, 70% adults, and then the rest kids. But last couple of years I was at a pediatric clinic, and thinking back to that, I would say probably most find a little bit of comfort in like, man, like, you're feeling depressed. Well, shit, like, Chester Bennington, Linkin Park singer, like on top of the world, a multimillionaire, like he was depressed enough to like end his life by suicide. Like, man, like we sit here and think like, oh, maybe if I had more money, if I had more friends, if I had fame, if I had whatever it is, and it's like, man, I don't know, I don't think it quite works like that. I think this is more of like an insidious and somewhat ever present like experience that we have to learn how to interface with. Um and so what I will often, if somebody does say, nah man, like I shouldn't feel depressed, I'll say, for one, like, I don't know, I've had random days where I wake up and feel really depressed and really anxious. And I won't say like I meet clinical like criteria for depressive disorder or anxiety disorder per se. Like I have those experiences for sure where I'm like, man, it is really hard to get out of bed and go to work today. And again, I think that's human. So kind of two thoughts off of that. One, this is by far the best time to ever be a human and to be alive. Like, you are significantly less likely to die by being a victim of a violent crime today compared to 20 years ago, 50 years ago, 100 years ago, and so on. Less likely to die in a war, especially compared to like 500 years ago when there's like skirmishes going on all over the place. We have much more access to clean water and food and medical care. Like, man, like this is by far the best time to be a human. But anxiety and depression have continued to rise, even as life has gotten more safe, more convenient, more efficient. So, again, I don't think it's a function of our external environment needs to be perfected for us to feel good. I think like feeling good is the enemy. Like, maybe life isn't about feeling good. And so, kind of to curtail like that thought, I'll ask clients like, is being sad bad? And go ahead, what would y'all say? Like, shooting from the hip, is being sad bad?
No, right? Like I think sometimes it's justified. It's like you were just saying, like life isn't maybe perhaps meant to be good. Like, my parents are getting older. They likely will pass before I do, but there's no, promises on that. Those are going to be sad. Geez, not just days, not even weeks, months, if not years, right? Like, so
Right?
it has to be part of the human experience. Like if you're living a life without any sad emotion as a psych resident, I'm deeply concerned about you. I've never been sad a day in my life. It's like, well, do you have any connections to any people? Do you care about anything?
Yeah.
It begs to question what's really going on.
So, similar, what you're saying is we hurt where we care where we hurt. You're sad at the thought of your parents dying because you deeply care about them. If I told you my favorite pet goldfish died, you might be like, oh, that's a bummer, but I assume you're not like actively heartbroken about Will's favorite pet goldfish dying, right? Like, it's not as like centered. So when people have a little bit of hesitate about like, how do we accept emotions? I say, man, like, I'll ask most people like, is being sad bad? Y'all are, you're in psychiatry residency. Y'all have probably a little bit different and maybe more sophisticated worldview and understanding of these things. But a lot of people, kind of to June's point, will be like, yeah, being sad is bad. Being anxious is bad. And I'll say, man, okay, that's fair. So two questions. One, say my mom dies today and I'm very, very close with her. Instead of being sad, I'm happy. Is that bad? Like, oh yeah, that's weird. Okay. So is being sad bad in that moment? And exactly what you were saying, Logan. Like, no, like it's normal. Two, think of any unpleasant emotion you can think of: fear, anxiety, sadness, all those things. There's not a single one of them out there that we haven't paid money to go experience. Sadness, man, like, how does Adele like sell out stadiums? Like, what do you do at an Adele concert? Like, you call your ex-boyfriend or girlfriend and say, I miss you? Like, it's sad as hell. uh Fear, we go to haunted houses, we jump out of airplanes, like we pay money to feel fear. Anxiety, play scary video games, like we pay money to feel these bad emotions. And these bad emotions aren't bad in the right context, so therefore they're probably not actually bad. They're just simple messengers trying to tell us something. Does that make sense?
Absolutely. And specifically, when we talk about anxiety and depression, I think there's a lot of external forces in our society today that's leading to maybe this false sense that these are inherently bad emotions. So, for example, right, the self help industry, right, we see book after book after book. How to stop your anxiety, get rid of depression, be happy. And then you have the pharmaceutical industry, right? With their Zoloft, Paxils, antidepressants, get rid of your anxiety, get rid of your depression, right? These are the messages that are being bombarded at us. So that was the point, that was the reason why I wanted to bring up that question that I asked earlier, especially concerning our kids, because I do worry that we're living in a world where we feel like depression just on its face is bad in every single situation. And I think, maybe a role that we have as psychiatry residents and as attending psychiatrists in the future is being having more of a clarifying role in that kind of regard. So, for example, one of the things that I like to stress with my patients, especially when it's a consult for depression, is hey, there's the ebbs and flows of life. Sometimes you can feel low, you can feel depressed. That's okay. The kind of depression that I'm talking to you about is clinical depression, the depression where it starts to affect your sleep, your ability to eat your meals, your ability to concentrate on your task is affecting your energy level. You're feeling hopeless, right? That's clinical depression. So in a way, I think I have this urge where I really want to stress to people that, there's clinical depression, but there's also this other type of depression that's very, very normal. And also that may possibly be good for you down the road, right? I mean, we appreciate good times because we know what it feels like to go through the sucky times. And we also can empathize with other people going through hard times because we ourselves have gone through those sucky times. So inherently, I think there is a lot of good in feeling depressed, in feeling anxious, as long as it doesn't elevate above a certain level. And I'm worried that in our culture today, we're losing more and more sight of that. And act therapy to me is, it's a breath of fresh air when I started reading about it. It's acknowledging, things for what it is and just recognizing that it's part of the human condition and focusing on what we're going to do to move things forward.
Right, right. And yeah, kind of like to your point where like, we're blaming all these external factors. And I think a problem is we end up getting on this like never ending treadmill of like, man, once I make more money, I'll finally be happy. Once I get a hot spouse, I'll be happy. Once I get a kid, I'll be happy. You do that. And eventually you realize like, man, I'm 87 years old and like much more time to figure out how to be happy. And again, like, and I think probably the most pithy and to the point explanation of ACT and how it differs from most other therapy approaches, short of maybe mindfulness-based CBT and DBT, dialectical behavioral therapy, is ACT is about, so other therapies are about feeling good. ACT is about being good at feeling. How do you feel depression and still live the good life? How do you feel anxiety and still live the good life? And by the good life, I mean a life according to your values.
Yeah, it seems like just like in a sense, if you could put it short, it's like sitting with the distress, like being with the distress. That's almost how I like, through this discussion, like I'm thinking of ACT therapy. So I guess I'm curious, I don't have the exact numbers in front of me. Maybe I'll put them in the show notes, but I'll probably forget. But so CBT, I've been tested on this a billion times. I feel like you too, Joon, and I'm sure you too, Will. Yeah. Will, are you Dr. Summers, by the way? Do you have a doctorate?
Yeah, I got my PsyD in 2020. Yeah,
there we go. So nice. A fellow doc on the show. Very good. Very good. So CBT has been shown to be effective statistically for depression and anxiety. That's my understanding. And the data around CBT for psychosis is not amazing. And like it's not, maybe it's really not that much better than what we're traditionally doing. I know it's very hard to study this stuff because like for me and Joon, it's placebo versus not placebo, or like standard of care versus new agent. How do you do that with necessarily talk therapy? I think it's making that hard distinction, hard place in the sand is extremely hard. But what I'm asking, I guess, is has ACT therapy been studied in the psychiatric population? What I mean for that, for the listeners, these are the individuals who live with what we call like psychotic features, hallucinations, like where they're hearing different voices, perhaps even seeing things, or always having these kind of like paranoid delusions or other kind of like delusional thought processes. So what is your understanding of that, Will?
Yeah, and to your point, I've heard similar that talk therapy has limited effectiveness when there are like active delusions, hallucinations, and those sort of things. I know that there were some research studies going on last I looked at ACT. When I was in Yakima, Washington, Logan,
Yakima.
I was at Yakima Neighborhood Health, and I don't know if you knew about that hospital.
I did rotations there. Yep. Mm-hmm.
Okay, yeah, so you know about that life. So it is a hospital for the uninsured, underinsured, and homeless, and like soon to be homeless populations of the area. And unfortunately, there's just a higher rate of psychosis, schizophrenia, and those things. So while I was there, I was looking into ACT for like these things that we're talking about. I know there were some research studies that were in press. It seemed promising. And again, my thought and hope is it's that flexibility piece. If you can say like, I'm noticing my brain is having a voice tell me to hurt myself. I'm noticing my brain is seeing somebody that other people don't see. And again, just a little bit of perspective and a little bit of looseness from it. I think that might be a pretty key ingredient. But to speak bluntly, like I don't know the exact like present day research on ACT for people with psychotic features.
Future episode we'll
Yeah.
do on it. There we go. Teaser.
So Logan, June, did you have a question or do you have a thought?
Yeah, well, I was just gonna change topics real quick. There's one question that I really wanted to ask you on this episode today. So Logan and I, on one of our recent episodes, we had discussed an article that showed that the rates of anxiety, the diagnosis for anxiety, is increasing. However, the rates that which primary care physicians are prescribing or recommending therapy is actually decreasing. And to be honest with you, that kind of broke my heart, because I do believe in the lasting effects of therapy. Right? I've talked about this many times on this show. SSRIs, medications, these are only as effective as long as you're taking it. Versus things like mindfulness, yoga, CBT, now ACT. I can say that ACT, right? I got to say ACT. These are skills that you can carry on with you. So even if you don't have access to your medication, these are things that you can always reach into your back pocket and pull these skills out to help you out in that moment. So my question to you, Will, is first, what do you think about that statistic that physicians are less likely to prescribe or recommend therapy now, even in spite of increasing rates of anxiety? And two, what can we do to get people more excited about therapy? What can we do to get that patient that's coming in to see their primary care physician? What can we do to get that individual to request a visit to the therapist?
Yeah. Oh, that's a great question. So first, with the rates of PCPs recommending therapy less often, I feel like that, man, it could be a chicken or an egg thing. One, I wonder if there is some sense of, I guess like the word would be like attenuation or habituation, a sense of habituation where it's like, cool, of my last 300 patients, 270 of them said they had anxiety. Like, get like it. I wonder if then the goalpost becomes a little bit moved to where it's like you'd have extremely severe anxiety for me to then like say it. Hopefully not. I imagine not, but I just imagine as a function of like normal human cognition of like, oh, some kid says they're anxious before getting up and talking to their class, or some kid says they're anxious to take their SAT this weekend. And again, those aren't quite like the clinical thresholds. So I wonder if maybe a tiny portion of it is that. I hope not. I suspect not, but I wonder. Two, what I think probably is the bigger culprit is the research on patients getting recommended to go to therapy from their PCP, and the follow through rate is abysmal. Right. Last I knew is about 10 to like 15%. So wow. Somebody goes to their PCP, says, I'm very depressed, I'm very anxious. PCP says, hey, you should go to a therapist. Call across town and go, that's a good place to be. Again, 10 to 15% will follow up. Even worse, the median, and so median, not average, median number of, modal. The modal number of therapy visits that any given patient will have with a therapist is 1.
Wow.
I don't know if y'all have had personal experience with the therapist. I have. I've seen 3 different ones throughout my life at different chapters. Your first visit is intake paperwork and intake questions. Where did you grow up? Who was in the house? How many friends do you have? All this stuff. So putting yourself in like a patient's shoes, doctor says, go to therapy. I go to therapy. I email 7 different therapists. 6 of them don't take my insurance. 1 of them says, right, I'll do a sliding scale. I have a 6-week wait list or a 5-week wait list. It's not the time you want. It's Tuesdays at 3:00. You have to leave work early. Sure, fine. I'll fucking make it work. So right. You wait 6 weeks. You go in on the first day, and the first day is just, here, sign like 17 forms, and then let's talk about like so many things that don't feel relevant to your anxiety. And so, yeah, of course that person doesn't follow up. And so I think what we might be feeling is like that experience happening logarithmically in our population, that like patients are less and less likely to follow through. And so like, yeah, I don't fault the PCP for being like, you should go to therapy, but like, I don't know if you can't afford it.
You can't get into it. Yeah.
Right.
And then I've even like heard of certain healthcare systems like only offering group therapy, and I've had patients being like, I'm never doing group therapy ever. I won't say which healthcare systems because I don't want to get sued. But Will, I'm very curious what you say when you have a friend or a patient or a client. You guys actually use the word client a lot more than I feel like me and June do in our kind of world of psychiatry. And I kind of like it seems like inpatient versus outpatient. Like outpatient, we use the word client. Inpatient, when we're in the hospital, we always use the word patient. But I
Yeah.
definitely like the concept of client. Like it seems like you're almost working on the person's behalf rather than
Mm.
this, I know better than you because I'm the doctor, so take X. Like I'm your client, like, or you're my client, excuse me. Like it almost seems like I'm your accountant, I'm your lawyer, like giving people a sense of empowerment, perhaps. So I'm working in a clinic now who kind of uses that language, and I like it quite a bit. But I'm rambling. Um, when someone, even if it's a close friend, family member, a person I see in a hospital or an outpatient clinic, I'm trying to find a therapist. What should I do, doc? Say, well, look, you can look in your insurance. It's probably going to be the cheapest if you even have insurance. If you don't, that's going to be an even bigger challenge. But you're likely going to have to deal with a wait list. And I do actually encourage a lot of individuals to check out one of those online therapy companies. We are not financially sponsored by any one of these. BetterHelp, Talkatry. You Google it. There's a bunch of them. I've had very good experience with them personally. I've heard good things from other people. They
Good.
are expensive, but if you want to get in quickly, it seems like that's sadly the only option, which is really depressing because then only the people with uh, money are able to get therapy quickly when they need it.
Right. So a couple of thoughts, and I'll have one little semi shameless plug on that. So June, and this kind of ties into what Logan was saying. Your question was like, what would we do to make therapy more engaging, more appealing, more inviting, and kind of as a function of that, increase accessibility. So when I was in Yakima, I was at Central Washington Family Medicine, and that's where I did my internship and postdoc. So just for listeners that are in medicine, and for y'all, I don't know if y'all know this as well. In psychology, if you're doing your PhD or PsyD, which is our equivalent of MD and DO respectively, for your 5th year, you do an internship, and I apply to however many places I can, get as many interviews as I can, and an algorithm, the exact same algorithm that y'all use, spits me out and says, this is where you're going for internship. So for what it's worth, I know about like the match day hell and the algorithm kerfuffles and all that mess. Except our servers don't shut down every day on match day. That's just an ACGME thing. So when I was in Yakima, sorry, my dog is pawing at me. Go away. So when I was at Yakima, I was at Central Washington Family Medicine, and it is what they call primary care behavioral health, PCBH. So when I was there, if somebody went to their PCP and said like, hey doc, like I'm having trouble stopping smoking, or my baby won't sleep, help me with some sleep tips, or I'm depressed, or I'm anxious, or I am seeing things that other people don't see, truly anything and everything. We were 100% trained for whatever presentation comes in the door. The doc could say, hey man, like that sounds really rough. I actually have a colleague who's here today and they can actually come see you right now. And so I would maybe be with a patient and I'd get a buzz and I just send back like, hey, give me 15 more minutes. Or I'd be sitting in like my little office that was part of the pods, like up there with all like the nurses and the physicians. And they'd be like, hey, Will, do you got time for a consult? Like this person has this. And I'd go in immediately. So I think like limiting or minimizing the barriers to getting treatment was huge. And at CWFM, they just put out the stats last month. I think it was something of like 35 or 45% of patients that went in saw some behavioral health provider at some point in the last year, which is like great. That's probably 90% of those people probably wouldn't have seen psychologists in any other capacity. So I think like increasing access by having more people in primary care, behavioral health, primary care specialties would be certainly one way to go. One consideration that people would often bring up is those visits are about 15 to 30 minutes long. Oftentimes people want a little bit longer, 30 to 45 minutes, 40 to 50 minutes. From what I know, there is no research supporting that therapy has to be 40 to 50 minutes long. As somebody who practiced in the 20 to 30 minute side of things, I felt like I could be as effective as I needed to be. It was just very like very to the point and very succinct, if you will.
Right.
So that's one consideration. Otherwise, and this is kind of to what you're saying, Logan, you're like, man, I go hook up with BetterHelp, go Better Tree. Is that the other one you were saying?
I don't know. If you just, I get all the advertisements now, maybe because I say the word
Okay.
therapy so much in my life and my phone's listening to every word I say. But yeah,
Right.
like, it's Michael Phelps is on the cover of them, and like, all of it, like the big ones, that are ranked at the top of the App Store and stuff when you type in
Right.
therapy.
So I'm also a member of Alma, ALM as in man, ALMA, Alma. And Alma is, as far as my experience on the clinician side of things, incredibly helpful in streamlining the process. Basically, clients they accept 3 different insurances and all the subsidiaries below them: Optum, Aetna, and Cigna, I believe. And basically, they just put in their insurance, and every clinician on that website takes that insurance. That if they put in their insurance, they put in Optum, I will come up. I 100% will take that insurance. So it makes the process a lot easier for them. And then, uh, as far as like wait lists, and this is just me specific, um, man, it breaks my heart and kills me that people are waiting 5-7 weeks for therapy. Um, maybe, man, I don't know. Whenever I've had people come in and like consult and ask to like get on my schedule, I typically has something within the next week or two. Um, but I'm also more than happy to be flexible with my schedule and be like, sure, we can work 7:30 at night on Thursdays. And so I might have a little more flexibility, and because that's when Kelsey has a late night with didactics and stuff like
Right.
that. I don't know how to fix the waitlist thing at this moment, other than encouraging
Run for politics.
yeah, exactly. And I'd say also encourage patients to see if their primary care provider has a behavioral health provider there. It could be a behavioral
Right.
health consultant, behavioral health provider, and again, that way you could just get right in.
Well, did you say your wife or fiance is in didactics till 7:30 p.m.?
So, so as a surgery resident, didactics, I think what it is it's all 1 hour later. Sign out's usually 5:30, but they start didactics at 5:30. So then sign out becomes 6:30, and so she's probably in didactics till 6:30. Does sign out until like 7:30, and then starts the
Boy.
trek home.
Oh boy, choose psychiatry, guys.
Yeah, we chose the right profession. So, hey, we've taken up about 45 minutes of your time. Joon, I'll give you one final question.
Well, I think I'm gonna go with more of a final thought. Well, during the course of this conversation, I was just kind of reflecting back on some of the conversation that I've had with some of the patients that I've had the privilege to serve. And one of the things that kept popping up was I would tell my patients that, hey, like if you can manage it, I think you should get up early and go to the gym and try to do that every single day. If you can't make it to the gym, hey, just get up, take a walk. If you can't do that, get up, walk down the stairs and walk back up. Because I think there's value in doing things that are difficult. And this conversation with you really helped me to contextualize, like what I was doing there. So what I'm taking away is that there's real value in acknowledging some of those negative emotions. Oh, I'm tired as hell in the morning. I can't get up. But if we acknowledge that as being part of the human experience, and if we're able to overcome that emotions through our actions, that euphoria, that dopamine release that we get from overcoming, the very resistance and the barriers that we felt were impossible to break through, I think there's real value in that. And I think that translates to other areas of our lives. So just as I tell my patients, like, hey, if you're able to do this little thing in the morning, I promise you it's going to translate to your relationships. It's going to translate to your work life. It's ubiquitous. This is a skill that you can continuously utilize and continuously build on. So for me, this is what ACT therapy is all about. And for that reason, and for it being very, very real and practical, I love it. And Dr. Summers, you've convinced me. ACT therapy over CBT all day. Let's go. I'm going to be looking more into
There
it.
we go.
I feel the same, but I won't say it quite as strongly. I will say therapy is effective. Do what works for you. I personally think ACT is infinitely more efficient. I'll be a little more diplomatic.
Right. Hey, something is better than nothing. So
Yeah.
CBT, ACT, whatever it is, something is better than nothing.
Right. See, spoken like a true politician, dude, over here. Look at him. See, he's going to be a therapist politician, and he's got it made.
I've told Kelsey I would love to run for something for political office. Moral foundations theory, which we didn't get to today, is a lot about the theories of like why people see things differently across the political spectrum. It is the stuff I geek out hard about. I love it.
All right.
Kelsey's
well,
like,
next episode.
Yeah, we got to bring you back for that one.
Yeah,
That was
yeah.
interesting.
Yeah.
Kelsey says she will not marry a politician. And real quick, if you're okay, I would like, if you're cool with it, give like probably like 3 different ideas of ACT that kind of capture the 6
That'd be
processes.
a great way to end. Yeah, do
Cool.
it.
So there are 6 processes. We won't go into them. Feel free to Google the word hexaflex, 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 and that will show you what I'm talking about. So the 6 processes can be kind of but simplified down into 3 pillars, just to make it more simple. The pillars are be open, be present, do what matters. So ACT therapy, in short, wants these 3 goals to be met. Be open with what your brain tells you, be present in this moment, and do what matters. So if I could give you like one idea of each of those 3 pillars, this would be what I would say. Be open is how to accept emotions. Again, I would say lean in, name, notice, and acknowledge your emotions. Like, man, this is a moment of anxiety. Make it very intentional in your brain that you tell yourself, I don't have to like it, but I'm not going to waste energy fighting against it. So name, label, and accept emotions and make it very intentional. 2, be present. I would say one thing that could be helpful is narrate the present moment. When your brain is pulling you into the future or pulling you into the past, narrate what you're doing. In this moment, I'm just driving to work. In this moment, I'm just doing the dishes. In this moment, I'm just doing deep breathing because I'm starting to feel a little bit anxious. So narrate the moment. And then last, do what matters. My favorite exercise is write about what if the next year of your life was going to be wonderful in terms of friends, family, career, finances, hobbies, all those things. If it was going to be a perfect year, write what that year would look like. If that isn't feasible, if you want something a little bit quicker, when you feel strongly about something, you feel anxious about something, and your brain says, I don't want to feel this way, ask, why is that important to you? I feel anxious. I don't want to feel anxious. Why is it important to you to not feel anxious? Because I want to feel comfortable. Well, why is feeling comfortable important to you? Because that way I can hang out with my friends. Why is hanging out with your friends important to you? Oh, because like, man, like I didn't have a good family life and my friends were always there to support me. Well, why is it important to have support? Because man, that just, it helps XYZ. So to be open, name, notice, and label emotions or notice thoughts like we were saying. Be present, narrate the present moment, and then do what matters would be write about your values for 10 minutes for the next year, like what the next year would look like, or ask yourself, why is this important to me 4 or 5 times? So dig into like what that value is. Sound good?
Hell yeah. No, that was a beautiful way to end it, man. Well, cheers.